This is Dr. Sargisian, and today we will have a review for our first topics, our topics for the first exam. And this is not a comprehensive review, but I wanted to bring to your attention what is most important, common things to know, and what will help you not only with your test, but it will help you in your professional future, in your career. So, just a reminder how to access the test. And I know all of you know already. So I'm on in my D2L side, and I'm already in our course Health Promotion for Older Adults. So in that point, our screens look fairly similar, and I would like to see how to access it. So I will go under evaluation. You guys see my mouse moving, and click it. Click assessment, and here are all my tests. On your screen, as you can see, on February 26th, this test will become available. Right now you do not see anything, but don't fret, it will appear. And it will stay available for just 1 week. You can pick your own times, and you can take the time convenient for you and take it. But don't fret if you don't see the test, obviously it will come up. Test is comprehensive of entire material we cover, but it's open book. Open book, it means you can search your notes, your books, but you cannot search internet sources. First and foremost, I would like to bring to your attention the assessment. So this is a course about older adults. So all the time, whatever you do in this course or in this field, you have to focus on older adults, such as in assessment part, you need to know how to assess older adults. I would like to bring to your attention 2 key points in the assessment. You have to know that there are common changes with aging, and you have to know that older adults have a typical presentation of fairly common disorders, not desirable but common. So, examples: if you are assessing someone in their early 80s or late 70s, what would you expect? You expect, for instance, dry skin, you will expect hypertension, and you may expect some loss of hearing. These are not good findings, but this is expected. On the other hand, if something critical is happening, such as myocardial infarction or infection, the older patients may not present typically. They may not have a typical presentation. In cardiac disorders, they may have absence of chest pain. In infections, they may not be able to produce a robust immune response. So this is my small overview of the assessment, but please know about common findings and atypical presentations. So next topic is health promotion and prevention. And I know, guys, you are so sick and tired of listening about primary, secondary, and tertiary, and it's really complex and at the same time is simple. So prevention, primary, whatever you do, it helps to prevent in the very beginning, at the root, the disease or disorder. Primary prevention example is immunization. So you don't have any disease presentation, nothing is happening, but you still administer vaccine to prevent. So a flu vaccination, influenza vaccination, pneumonia, shingles, these are all examples of primary prevention. And I'm bringing vaccination example because this is really pertinent to older population. Secondary, what's secondary? Secondary is, okay, we may have a disease, but we are hoping that there won't be a disease. Secondary will be a screening, any type of screening, cholesterol screening, and you guys remember, you're welcome to Medicare exam was involving cholesterol screening. So welcome to Medicare is an example of secondary prevention. Tertiary is not good, but we're still doing well. Patient came with atrial fibrillation, and you stabilize the rate, and you started giving anticoagulants at the same time. So it's a tertiary prevention because you are preventing cerebrovascular accident at this point. So again, primary, secondary, and tertiary. So the next one I would like to talk about is functional assessment. Functional assessment is a very tricky situation when you are studying about it at graduate level. In undergraduate, we remember that this was mostly about ADL and activities of daily living. But in graduate, we are emphasizing basic activities of daily living and instrumental activities of daily living. What does it mean? And why do we do that? Because unlike your undergraduate curriculum, when you were prepared to provide the care mostly in acute setting or maybe in community setting, but here you are decision making. So by doing this ADL assessment, you actually may decide, can this person live independently, or they need some assistance, or they need to go to assisted living, for example. So basic ADLs, basic activities of daily living. Basic means this is needed. This is very needed for survival. And it's walking, feeding, dressing, brushing your teeth, bathing, transferring from chair to bed. Can that person do it independently? That's your functional assessment. So you can say they do basic activities of daily living. So basically they can survive, but can they thrive? And to check that, or thriving in this situation means, can they live independently? Is the instrumental activities of daily living. In old days, they would always bring balancing the checkbook. These days, nobody balances the checkbook, especially the millennials. But still, some people may balance checkbook, others may be able to access it online or on their cell phone using an app. But one of the key instrumental activities of daily living is managing finances. The other one, managing transportation. Can they drive or can they take a bus? And the other one, shopping, meal preparation, grocery shopping, cleaning the home. So being able, the other one, to communicate. Can they call on phone? Can they use phone, internet, texting? It sometimes can be complicated. And so, and one of the main ones is, can they manage their medications? Do they know what to take, how often can they manage that, or they need assistance. So every time you do this functional assessment, it's case by case basis. Some of your instrumental activities of daily living will be impossible for the patient to implement, but they still can maintain the independent living in their home, just with very little help. Another topic that we'll talk a lot about is, and you had a whole module on this, or part of the module, I will correct myself. It's pre-op, post-op management. It's pretty clear cut, but there are some things that you need to screen the patient before the surgery, such as hypertension, electrolyte levels, presence of the certain disorders, and a good example is anticoagulation. If they are again on warfarin or something else, or Xarelto, you may need to stop the medication, or you may need also to screen what's going on with their PT and INR before the surgery. Polypharmacy is another topic, and we certainly were talking about it a lot. Still know that polypharmacy is not good. Polypharmacy is manageable. You may shrink that list of numerous medications to essentials and just help the patient to have their life more manageable. I'm going back to instrumental activities of daily living. When we're talking of medication management, patient may actually be able to manage their medications if they don't have 115 medications and they have only 5. So the last but not least, Beer's list. Please know what's on it, and there was a separate video for it. And Beer's list is important. Again, for those of you who think that Beer's list is the list they give you in the local brewery, please reevaluate that statement and go back to your book and that video I posted, and I promise it will change your mind. So it's not the list that they give you in the brewery. Next topic I want to talk is 3Ds. Oh my God, in 3D, you guys remember when 3D movies appeared, they give you those glasses and so on. So I'm not talking about that. 3D, it's dementia, delirium, and depression. So important things. Assessment again. How to assess, how to know what's going on. Just for a little review, if you're trying to assess your patients, know that what mini mental status examination means, mini cog, drawing the clock, what's the meaning of it, and what's the how you can use it in your practice. And if patient developed dementia, there is treatment these days. Is it effective? Maybe not extremely effective, but it's still possible to help those patients at least to slow down the symptoms. But if you do the treatment, please know what kind of side effects can this cause. If you're giving Aricept or Namenda, those medications have like severe GI symptoms, and risk versus benefit versus limitation. You always think about it. Is it worth Does it worth to subject your elderly patient with advanced dementia to GI upset when you are giving them Aricept or Namenda, while they really do not have that much of life expectancy? But to make that decision, you need to know that these medications may have side effects, how you prescribe it, when this is appropriate, when it's not. And non-pharmacological treatment, what can be done to help this patient, and also when it's appropriate to refer. Depression may follow elderly patients for long time in their lives, or may be appearing late in life. But in both cases, when patient came to you, you need to evaluate. When you are evaluating, pharmacological treatments may be appropriate. However, things like group therapy may help, or referral even to psychiatry if it's advanced case. Dealing with depression, it's a very uh, difficult and at the same time rewarding situation for practitioner, but you need to know several things. If you are dealing with depression, make sure it's not an organic cause, hint hint, thyroid. If you ruled out organic cause, then you may consider situational depression. What's situational depression? If someone is grieving, it will be not expected if you lost someone close to you, even your pet, a cat, a guinea pig, or a bird. I'm not making fun. People are very attached to their pets, and or a loved one. It's appropriate and reasonable to expect that person may have a depression, but do we need to throw drugs at them? Usually not. You may consider grief support, or whatever the situation is, support groups. You may consider psychotherapy, you may consider counseling, but think about that the situational depression is really a normal response to a situation, and you can help your patient to climb out. So if it's situational, medication may not be appropriate. If depression doesn't have situational or organic character, at that time you may consider giving medication, pharmacological treatment, but at the same time, please refer to your Beers list and see which of the antidepressants or which of the treatments will be appropriate for your elderly population. So, on this note, I'd like to conclude. These are not all of the topics that covers this first few units. I call first few modules, I'm sorry, I call it unit 1 before exam 1. But please review all of the material and also pay special attention to these topics I just talked about. And I wish you good luck, and please contact me if you have any questions, or if you have something that is not clear in this content. And this is the end.